All right. Welcome everyone back to another virtual shouting session at Hearts for Health. We hope your weekend went well, and we're excited to start off the week with our session today with Gaby. Gaby is a board certified PA. She has extensive experience in nutrition education and also diabetes management. She's originally from Venezuela and is a Spanish speaking provider. So we're very excited to have another PA join us for shadowing. We know a lot of you love to see our PAs. And actually, we're going to be having another one next week on Monday again. So definitely looking forward to that. For a few reminders, though, I know some new people sometimes join in on each of these sessions. So if you're unfamiliar with virtual shadowing, we have new speakers and new faces, new specialties, both PAs, physicians. We also have dentists. And really, we're expanding to other specialties and other fields outside of those three, too. You can stay tuned with us over Instagram and also our listserv, which I'm going to be talking a little more about later on in order to know who's going to be the next speaker. But we have a lot of specialties and a lot of speakers join us. We're almost at session 50. But yeah, it's a very involved and engaging experience. You can basically get shadowing virtually. And in order to get your questions across for any speakers, we have time at the very end for a Q&A. So if you see to either the right of your screen or below this live stream video here, you have the Q&A, or you have the chat box, I should say, where you can type in your questions for the Q&A. That Q&A will be at the very end of Gaby's presentation today, and we will go through questions in the order that we receive them. Like I said, you can stay updated with future shadowing sessions, either through following us on Instagram or a listserv. To get added onto our listserv, either email us through shadowing.h4h@gmail.com with your email and your name, and we'll get you manually added on. Or we have our website. If you go onto our website, go to the very bottom and then go onto the subscription form, just fill it out and click submit. You'll be good to go, and we'll be added on the listserv. The listserv is just a weekly email, mainly for our shouting program, and you'll see the new speakers each week. We have 2 new speakers on usually Mondays and Thursdays each week, again, from a variety of specialties. But if you have any questions outside of that, feel free to let us know. I just wanted to cover the primary reminders, the main reminders for shadowing in general. With that said, though, I don't want to take too much time, so Gaby, feel free to take it away.
Awesome. Thank you, Michael. Thank you so much to the Hearts for Health team for having me tonight. I'm very excited. I've done a few virtual shadowing sessions in the past, and they seem to be a great way for students to learn about the PA profession, and that there are, non-traditional pathways. And in particular, that's one of the reasons I love the PA profession. So I hope you guys learn a thing or two tonight. So let's get started. So as you can see, my name is Gabriela de Vita. I go by Gaby. I'm a board certified PA, diabetes educator, and registered dietitian. So that's it. There we go. This is kind of how I'm going to do the talk today. We're going to talk a little bit about my career timeline, each of these 3 credentials, my experience as a PA in these different fields, and then we don't have a Q&A at that point. We'll go into the case studies and then the final Q&A. All right, so as far as my career timeline, I, like Michael said, I'm originally from Venezuela. I came to the US in 2011 after I had already started my undergrad. And I kind of had to do an international student visa, and in 2014 I graduated with my bachelor's in dietetics and nutrition. At this point, I didn't even know about the PA profession. That's what my initial interest was in, dietetics and nutrition. And so I just went that route. I became a registered dietitian in 2015 and started working in diabetes during pregnancy. And then in that job, because my day-to-day was diabetes education, I went on to obtain the certification for diabetes educator. It has changed names now, but still the same thing. And then around 2017 or so, maybe 2016, that's when I learned about the PA profession, and I was attracted to it for different reasons that we'll get into just a second. In 2018, I started PA school, graduated 2 years later. It was a full-time program, and started working in family medicine. And after about a year and a half or so, I moved on to now I have two part-time jobs. So I do primary and urgent care, and then I also do maternal fetal medicine. So that's a little bit of my entire career timeline. So I just want to kind of go over a little bit the credentials, because I feel like, not everybody knows what a dietitian nutritionist is. And I've had a few dietitians interested, in learning more about how to make this career change. Initially, I chose to become a dietitian because it was a career in medicine. And as a dietitian, you are part of a multidisciplinary team, and you can have a high level of involvement in care depending on what area you work in. But in the clinical area, which is what I liked, dietitians are very very involved with care, especially something like dialysis patients, diabetes, and those were my areas of interest. There's also a huge focus on health promotion and disease prevention, so it's not all diet and weight loss and things like that. But again, as far as in the primary care setting, kind of helping these patients stay healthy and avoid disease. And just the ability to work in many different areas. And it seemed like it had a good work-life balance, right? A lot of people interested in finding good work-life balance. How do you become a registered dietitian? This is an entire, career on itself, right? So it's a bachelor's degree that you have to complete in a credential university. And then you are going to go into the clinical rotations. These are 8 to 12 months or 6 to 12 months. Mine was 8 months. They also have to be accredited. And for most of the programs, you actually have to apply. So once you complete your bachelor's, then you apply for the supervised practice program. And once you do that, then you can sit down for the exam. And to maintain your registration, you keep on CEUs. And where do dietitians work? Hospitals, long-term care facilities. I love that you will see dietitians as part of a sports team. Like I actually have one of my very good friends. She is the dietitian she's in Mexico, and she's a dietitian for the national soccer team in Mexico. And I think that's just amazing. Private practice, any like food and nutrition related business industries like pharmaceuticals as well. And the community public health. So, and then obviously medical centers, universities. So lots of different areas. I went for the hospital route. And that's how I got started into this medical world, I would say. So this was my first job. It was in the diabetes during pregnancy program. It was a very unusual job because you had to have experience to get in this position. And I had zero. I was just graduating. But I still apply. And so that's one tip I always, tell everyone is, even if you don't have the experience, still apply for the job. And in this team specifically, so my role was to provide diabetes education for patients with type 1, type 2, and gestational diabetes. And I did that. I started with one of our group classes for gestational diabetes. And then as I started to gain, more expertise in the area, I went on to type 1s and type 2s and doing one-on-one educations, follow-up. And by year, I would say after about a year or so, I was doing blood sugar management. So basically looking at the blood sugar logs for the patients that they would send every week and kind of interpreting those and based on the patient's diet, deciding if they needed medication or not. And from this experience is how I realized that, wow, there's a lot more that I can do that I really like. And I started to kind of feel kind of narrow in my scope of practice. It's throughout that time, like I said, about like 2017, I became a diabetes educator, which the new name is a certified diabetes care and education specialist, kind of a long name. I really like this certification because kind of like PA, this welcomes everyone, right? So you can be a nurse, dietitian, a pharmacist, PA, a physician, and there's even a few other professions that can obtain the certification. You do have to have, certain years of experience working in that profession, like your credential that you're in, and then in diabetes. So for me, that was very easy because that was all I did, diabetes education. But maybe, a physician who is in primary care or another provider who is in endocrinology, those would be really easy areas to get all this diabetes education and then be able to meet the criteria to sit for this exam, which is another long exam, and then you maintain continuing education credits. So around, like I said, 2016, 17, I actually met a PA at work. I was getting referrals from a PA. And around that time, I was just kind of thinking, I feel like I need to expand my scope of practice. What can I do to achieve that? And there was an option for a master's program, like in public health, or I could go on to a master's program in nutrition and dietetics. But I didn't feel like either one of those options would allow me to practice medicine or like expand in my my reach with patients. So a coworker, she suggested, well, you could look into PA. You could be a great PA CDE and maybe work in endocrinology or primary care. So I talked with this PA and then I just fell in love with the profession. And some of the things that I liked back then that I said, okay, this is why I want to become a PA, is that you're a licensed medical provider, the wide scope of practice, and this comes with that lateral mobility, right? As you can see from my own journey and experience as a PA, I've been in family medicine, in primary and urgent care, now in maternal fetal medicine. So that ability to switch specialties without any farther like formal training, that was very attractive to me. The collaborative environment. So as a PA, you are working with a collaborating physician, which is very important to know. It's a collaborative environment and collaborating physician, and we're kind of trying to move away from this supervising physician, because with that, it used to be like, it would be understood as the physician has to be in the same area or in the same location to kind of supervise your practice, and that's not true. In SPAs, you actually have a lot of autonomy, a lot of independence, depending on the practice or the setting that you're in. And this last one, the education to practice timeline, was fantastic because I had already had a career. I had already been working, and I didn't, even though I wanted to, go back to school and expand and all these things, I didn't want to take too long to achieve that. So when I say education to practice timeline, I'm referring to that 2 to 3 year program. And then as soon as you're done with that, you're able to start practicing, start working as a medical provider. Whoops. So what is a PA? Probably most of you are familiar with this, but this is a definition that comes straight from AAPA. We are medical professionals that diagnose illness, develop and manage treatment plans, prescribe medications, and serve often as patient's principal healthcare provider. We have thousands of hours in medical training, and we're very versatile, like I said, with the ability to work in different fields. Where are you going to see PAs work? We work in hospitals, urgent care centers, in outpatient clinics, and pretty much in every specialty and subspecialty there is. You, like in primary care, urgent care, family medicine, even like pediatricians, OBGYNs, sometimes in these settings, the patient will only see the PA. Again, depending on the practice specifically, but say where I work, the patients will only see me. They won't usually see the doctor. It's like I have my own set of patients. The doctor has their own set of patients, and unless it's a kind of complicated case, this is where the collaborative aspect works or comes into play. I can discuss it with the doctor, or I might say, I want you to see the doctor next time you come, something like that. So what do you need to become a PA? You're gonna have to have a bachelor's degree and meet the prerequisites. This is one of those things I really liked about the PA profession is that it welcomes career changers. It welcomes everyone. And when I have students ask, what's the best major to go into PA, I always say, whatever you want, whatever you like, as long as you're meeting the requirements, the prerequisites for the schools that you want, just go ahead and do something you like. I'm a big fan of dietetics and nutrition, and I think that you're going to have, this knowledge base is going to be very useful as you become a practicing provider. But you should go and just do something that will be fun for you also, enough with like all the biology and chemistry and stuff that you'll have to take that probably is not that fun. You're gonna have to be working. You're gonna have to have patient care experience, health in the healthcare setting, volunteering, and then I'm gonna compare this with how it went for me. But shadowing, volunteering, leadership, these are things that are going to help your application be more complete and competitive. Sometimes they're not mandatory, but they're highly recommended. And then you're going to apply to an accredited program through CASPA. Most programs will require you to have these exams like the GRE, the PA-CAT. And if you, like me, if your first language is not English, you might need what's called the TOEFL exam, which is like an English proficiency exam. Even though I had graduated here in the US, I still had to take it for the school that I went to. It was crazy. And then letters of recommendation and your personal statement. So then once you apply and you get in, you're going to go into a 2 or 3 year program. There's actually dual programs, and there's many ways to become a PA as far as the school goes, because there's 5-year programs as well that are direct entry from high school. So you graduate from high school, you go into a 5-year program, and you're a PA by like 21 or 23 or something like that. And then you sit for your licensing exam, your PANS, and that's it. So just to kind of give you a little bit of a summary, this is kind of wordy. I'm sorry about this slide. But my particular path was I had my bachelor's in dietetics and nutrition. I worked for about 3 years as a dietitian and diabetes educator. And then while I was working, I actually had to complete many prerequisites for different reasons. Either I never had to take them before, or they had expired, because the classes will only go, I think, about 6 years or so that they're kind of valid to apply for a program. So I was doing that. And then also I had to get shadowing hours. Like I said, they're not mandatory, but they're highly recommended, because you want to be able to know what the provider is that you're trying to become, what they do on a day-to-day. And if you can shadow in, different specialties, the better. So this is not just for PA, but if you want to be a doctor, MD, DO, or NP, go ahead and shadow. And as far as volunteering, I did a lot of nutrition education programs because that was the area that I liked. And for my application cycle, I applied one time, I applied to 2 programs, and then had 1 interview and 1. So I was accepted to that one. My program was a 24-month program full time. So I had to quit my job as a dietitian and then go to PA school. But my school, the University of Detroit Mercy, they also have the 3-year program, which is really nice for people that maybe have a family or can't stop working full time. Your first 2 years would be part-time, and then the 3rd year it's full-time because it's the rotations. And then they also have that 5-year high school to PA type of program. As soon as I graduated, I took the PANS about 2 weeks later, and I passed, and I started working within 3 weeks, not even a month after I had graduated, I started working. So I was really lucky in that sense. I always like to share this because sometimes people kind of get, a little hung up on the timeline and your goals and things like that. But it's never too late to go after your goals and to follow your passion And also know that your goals can change and things will change as time goes by, and that's okay. So kind of be patient with yourself. And if, you don't like what you started with, it's okay if that changes. All right, so let's talk about my work experience as a PA. My first job was in family medicine. This was my first job out of school. Like I said, I started here within about 3 weeks that I had graduated. And this was a job where I actually did 2 of my clinical rotations. It was I want to say my second rotation. And then in your clinical year in PA school, you're going to have a preceptorship. Most programs do anyways, which is your very last one. And you're supposed to practice at the level of a new grad at that point. You're still going to have your preceptor, but you should be pretty proficient. And so that preceptorship, you should do it they'll have you do it in emergency medicine, internal medicine, or family medicine. And you kind of are able to choose, at least for my program, you were able to choose where to do that. So I knew I wanted to work at this location because they had a heavily Hispanic population. And as we talked about earlier, I'm Hispanic, my primary language is Spanish. So I was just naturally attracted to help this population. I wanted to find a job with them. And so I called them. One of my professors said, just give them a call, try to get your preceptorship there. And then I did. And some point throughout my clinical year, I also asked them, like, listen, I want to be able to work with you when I graduate. Do you know if this is going to be an option? And this was like, I would have never just, be that upfront, but one of my professors, she highly encouraged me to do that, and it worked. At the time when I asked them, they said, we don't know what's going to happen, because I remember that was like 6 months ahead or something, and they're like, we don't know, possibly, so I was like, okay, at least they know I'm interested. So then I went in and did my preceptorship, and in that second rotation I had with them is when they offered me the job. So this is just a little background to say, once you get to this point, treat every rotation as a job interview, or anything that you do, even if you're shadowing, if you are, volunteering, whatever you do, always treat it as a job interview, because these are connections you're going to make that will help you later on in your career. And you never know who the person is going to be that's going to extend you that next opportunity. But going back to family medicine, one thing that I liked about family medicine was the wide age spectrum. So we see from babies to elderly in family medicine. And with that comes a variety, like a huge variety of conditions and medical complaints that you will see. This can be, I have to say, it can be very overwhelming at first as a new grad, especially because you have to know so much of so much of so many things. And as a new grad, it can be a lot. Luckily, you will typically see a lot of the same things. Like in family medicine, you see a lot of kid rashes and diabetes and high blood pressure and high cholesterol, things like that, headaches. And so you'll get, it'll get easier, but that extensive list of medical issues was very attractive to me because I thought it would help me kind of solidify my knowledge base. At this particular clinic, they do a lot of minor procedures in the office because it also functioned a little bit of an urgent care. Well, I'll talk about that later too, but because of the population we served, it was in Detroit, in the underserved population. These patients didn't really have urgent cares nearby. It was basically go to the clinic, the family medicine doctor, or go to the ER. There wasn't a lot of in between. So they would just come to our clinic because we took walk-ins. So it would be easier for them. So I saw a lot of urgent care complaints in this setting as well. And the hours and the autonomy were two other things that I liked about family medicine in general. You know, family medicine, you typically work maybe a Monday through Friday, office hours, like 9 to 5 kind of thing. I didn't have any on call, but I also didn't have any administrative time. Some offices will have you do, and especially now after COVID, you can find primary care jobs where you have maybe like a half day that you work remote or a full day that you work remote, and those are your admin times. And admin means going through lab results, calling patients back, test reports, things like that. Calling in medications, finishing the charts, things like that, that you, it's like another side of medicine. It's not always patient contact. There's that other portion that will require time too. And I just wanted to go over these two kind of together because they overlap a little bit. My second job that I'm in right now is primary care and urgent care. And at this particular job, I'm part-time. I do 2 12-hour shifts, and similar to my previous job, I have a combination of complaints with urgent care and then the primary care. The difference with this primary versus family medicine is that we don't see babies. Before, I would see like from newborns all the way to elderly. At this location in primary care, we start seeing patients, I want to say it's after 1 year old. But it's that combination, the continuity of care as a primary care provider is one of the things I love. But also it's nice when you have urgent care cases that are quick visits, like a patient will come in, I think I have a UTI. And you see that patient, you diagnose them, manage them, get the medication, and they're out the door and you move on to the next patient. So that's a little bit refreshing at times. Again, there's a lot of autonomy as a single provider. I am at this location, it's only one provider per day. So I see every patient that walks through the door, and the physician is available for me. Like I said earlier, if I have a question or a complicated case or something like that, but I don't have, a physician looking after every patient I see. And then there's one good number of procedures, which again, this overlaps with my previous job, but also my previous job was a little bit unique because I've talked with a few other primary or family medicine PAs, and they don't see a lot of procedures in the office. As far as procedures, what procedures I typically do are pelvic exams, INDs for abscesses, incision and drainage, sutures, injection for I'm blanking on the name right now, but there's a condition where you get bald spots, and I'm sorry, I forgot the name right now, but injections for that, they're like steroid injections in the scalp or like joint injections.
Is it alopecia?
Alopecia, yeah. Thank you so much. I was totally blanking. What other procedures? There's lots of like casting and splinting, ingrown toenails, which I hate those, but you get a lot of those in the urgent care setting. And it's the same things I did here, I did in my family medicine job. As far as, maybe I already went a little bit on this, but the type of appointments that I would see, annual well visits and health maintenance exams, this was usually either required by the insurance or their work. A lot of the times the patient will come in because their work has them do a regular exam every year. Follow up on blood results, education, next steps on any kind of condition they had. Blood pressure, diabetes follow-ups, like I said, pap smears and women's health, medication refills, sick visits for quick things, and lots of ER and hospital follow-ups. Common chief complaints, I put them all in the same page because, again, they overlap a lot from these two jobs, but the checkups and med refills, joint pain, any kind of joint pain, lots of people coming in with, shoulder, elbow pain, knee pain. Headache is a pretty common complaint, and a big one. There's many different things that can cause a headache: cough, asthma, COPD, a lot of skin conditions that you'll see in the primary care and family medicine field. A lump on skin, which can be an abscess or can be a cyst or many other things. Abdominal pain and constipation, and a lot of mental health also, that you will see in primary care and family medicine. We're kind of that first stop for patients in all areas. And then from here, we would try to manage a lot of the things in primary care, but we also can refer out for specialties, right? The thing is, when you refer to specialties, sometimes patients get lost in all the follow-ups and sending them to different providers. And I don't know if this is because of COVID or not, but the specialties, they have a very long wait time. So I have a patient with an issue now, they won't get into specialty like in 3 months. So that can be an issue. And that's one of the challenges too of family medicine and primary care, is that a lot of the complaints fall onto you, and you're the primary provider, helping this patient sort the things they have, and kind of guiding them through and trying some of the different treatment plans, but also knowing when to send them out. And then in urgent care, most of the same things, but also like suspected UTI or STI, COVID test, patients that have maybe a fall or something, and they don't know if they have a fracture. And now, even though they're the same complaints a lot of the times, urgent care, like I said, it's because those are quick visits. Your treatment plan is kind of based on, okay, what can I do for this patient here right now to make sure that they get better, or that their condition starts to get better. And then you send them to family medicine or primary care. Then they follow up. Now, if you see a patient for some of these complaints in the primary care side, it's a little, I'm sorry, I have like finger in the camera. You see these patients in primary care, then you are that provider that they're going to have to follow up with. So you might be able to go a little bit into more detail about their complaint, and then you can follow up with this person. And that's that continuity of care I was talking about. A typical day in family medicine looks like this. I would get to the office around 8:45 and just be ready to see patients all morning. This was a walk-in clinic, and there were 3 providers. So it was 3 providers every day. So we kind of had our own patients that we would see, but also there were other patients that would see anyone. So it was kind of a first come, first serve. As patients start arriving, you start seeing patients. And then I had a lunch break, usually right around 1, because the clinic wasn't open back for the afternoon, until about 1:30 or so. I had a little bit of time to just look at lab results, faxes, things like that, insurance paperwork, and then go back to see patients. And with COVID, and we were doing the telemedicine, around 4 or so, I would try to call back usually COVID patients is who we would see in telemedicine. And then by 5, I would go home. So this is what I said about the excellent hours. At least for me at this job, it worked really well in that sense. There were days that I would stay there later, 5:30 or 6. There were times I had to bring charts home because we would see so many patients. But typically it would be something like this, like kind of 9 to 5. The primary care clinic or primary urgent care clinic, it's a little bit different. I have the 12-hour shifts, and you see there's no times here. This is because I'm just seeing patients either all day long or back to back. But sometimes it's like everybody walks in at the same time, like last Friday. The first 2 hours, I didn't have any patients. So I was just reviewing claims, the administrative type of work that you have to do. But then about 7 patients walked in back to back or at the same time in the next block of hours, like I don't know, 4 hours. It was just very busy. So I would get lunch whenever I could and just continue to see patients. And then somewhere in there's also telemedicine patients. Now here, everyone, I can see anyone for telemedicine, especially my primary care patients that need follow-up on lab results. I don't need to bring them back into the office, and I can just see them in telemedicine. And that's one thing I really like, because it makes it so much easier for everyone if it's just a quick visit, especially for the patients. They can, be at work, maybe on their lunch break or something, or on their break, and we have a quick appointment, and then they go back to work. They don't have to take time off from work and things like that. So that's nice. Now, my other job in maternal fetal medicine, this is really interesting because if you remember, as a dietitian, my first job, I was in the diabetes in pregnancy program, and I was doing the dietitian education and a little bit of the assessment of the blood sugar. Well, now I'm back with this team. So I love how it's a full circle and how it just reinforces what I said earlier about treat everything like a job interview and make connections and stick to those connections, because you don't know where the next opportunity is going to come. And so my collaborating physician now, he was a resident when I was working there as a dietitian. And now he's the director of the maternal fetal medicine department. And over the years, the diabetes program kind of vanished, and he's trying to build it back up again. So he reached out to me and said if there was any chance that I could come join him. And it was just like the right time and the right place, because when he reached back to me this year, I was in my maternity leave. I had a baby in January, and that's when I decided to switch jobs. That's when I stopped working my previous family medicine job. And after my 3 months kind of leave, I said, okay, let's start looking for jobs. I had the primary care lined up, but I still had like my other half of the schedule kind of free. And so this was just a wonderful opportunity. And he basically said, we want to rebuild the program. We need a lot of help. We need somebody that knows diabetes in pregnancy, the education, but that can also prescribe the medications and adjust all the insulin and everything. And I said, as long as I can do this from home, then it's fine, because now I'm about an hour away from this hospital, and with a baby, I was not going to be able to drive up there. And they said, yeah, with COVID again, there's a lot of things that are done via telemedicine. So this happened to work so beautifully. I've been doing this job with them now for like 3 months. And the way that it's different from what I was doing before is that I am now, number one, doing the telemedicine consults, but I'm doing an entire consult. So I go into the entire patient history, which before I didn't. I was just providing education in general, but now I go through each patient history. I go into detail about their medications and other things pertaining to their pregnancy. And then we get into diabetes, how it's affecting how it can affect their babies, the risks for mom, for baby, how it's managed. We go into the monitoring of the baby during the pregnancy, recommendations for delivery. So maybe like if depending on what kind of diabetes they have, if they're going to need delivery by 39 weeks or 38 weeks, if they need extra ultrasounds or non-stress testing, things like that, I can go into that now, where before that it was nothing that I would address. And I still do the determining the need for medication, assessing their blood sugar levels. That section kind of stayed the same, and I still do that. I also do more of the type 1 now, which this is diabetes that usually comes from earlier, like in childhood. And these patients are a lot harder to manage as a type 1 diabetic, and they also have insulin pumps. That is also very challenging to manage, and I do that management. I'm in charge of seeing all the type 1 patients that are usually working with an endocrinologist, but then in pregnancy they get transferred to me, and I take care of the entire pregnancy as the blood sugars go. And then, like I said, I do this from home, telemedicine only, and I do 2 shifts at home, 8-hour shifts. So in general, my schedule is pretty nice because I have a full-time schedule with 40 hours. Sometimes I go over, like this happens in any specialty, any job. But I have 2 days away from home, and then 2 days at home. And then I have 3 days free, which is kind of a nice balance. And one of the things I like about the PA profession is that versatility. A typical day here, I do 8 to 5, and I do have 1 full hour lunch break. And usually I have consults in the morning and in the evening, but I might have maybe like 2 or 3 back to back. And then there's some kind of break throughout the day where I can follow up on blood sugar logs, where patients will email them to me or send them on my chart. And I'll just kind of show you this a little bit. Take out the time, but like this is a type 1 patient. I know you don't see my screen too big, but like it looks like this. These are like graphs for the diabetes patients with a pump. So I would go over all of that information, talk to the patient, and then adjust their medication. And every 2 weeks I do have a meeting with my collaborating physician where we talk about specific patients, and that's a really nice kind of way to collaborate, I would say, because I will see the patients for consults, but then he sees them in the office when they have to go for ultrasound. So this way, there are specific patients that we both need to be kind of aware of on how we're managing, how we're treating them, and so for him to follow up. So that's kind of how my days go. Okay, so that is that for all of my experience. Yeah, okay, we still have some time. So I have some case studies. The first one, I love this first one. It's a little bit more intense. I meant to leave this one for the end, but it's fine. I really like this case study in particular because this was a patient I saw in my first few months, I think, as a PA. And it's a patient that I will never forget. I have full permission to discuss, all these things, but some of the things are kind of adjusted a little bit, but all right, let's get into it. So this was a 67-year-old male. He had a past medical history of arthritis of the knee, and he came in for abdominal pain. Remember, this was at my family medicine job where people would come in also for kind of urgent care type of complaints. They would just avoid the ER at all costs. So this patient came in reporting an intermittent abdominal pain for 1 month. His pain, he said, was diffuse, sometimes epigastric, felt like burning sensation, often with foods, or like if he would get upset. He said he resolved on its own. It usually didn't need any medications, but the pain had increased in frequency in the past couple of weeks. And last night it was the worst. He did take some tramadol, which is a control medication that he had received for the knee pain. I can see I had this question here, like, what else do you think we need to ask? I wanted to make this a little bit interactive. I don't know, Michael, if you can, if they'll type things and we'll read them, or should I just keep going?
Yeah, absolutely. So we have a slight delay for the live stream. So if you want to, like past speakers have done this, if you want to ask your question and then go through the rest of the cases, give it some time for answers to fill in, and we can go back to the question for answers.
Okay.
Does that work?
Okay. Yeah. So, okay. So then at this point, we kind of had a little bit of a background, right? What's going on, but what else do we need to ask? So We want to know about his diet because he had said that it sometimes happens with food. So he eats a lot of Mexican food, fried foods. He didn't drink lots of water. He had no nausea, no vomiting. His bowel movements were regular with no diarrhea, no constipation, no blood in the stool. But he admits that last week he had green stools. He was voiding regularly, but the urine seemed dark, a little bit red, dark this morning. Otherwise, no urinary complaints. He didn't think anything about that. And he is a non-smoker, no recent travel, no regular medications other than the tramadol for the knee. His vitals, these are his vitals. He was doing pretty good, pretty stable. His physical exam, he was alert and oriented ×3, very pleasant, no guarding, no distress. Lungs were clear. His heart exam was pretty normal. And then on his abdominal exam, he had diffuse, TTP means tender to palpation. He had positive bowel sounds in all quadrants, negative Murphy sign, which I want to know if you guys know what a Murphy sign is. And no rebound tenderness, no CVA tenderness, which is costovertebral. Typically, we do that for kidney stones. And then his pulses were all good. At this point, what are we thinking? What is our differential diagnosis? What things can I do at the office? Which again, this was family medicine. So this is what we're thinking. The first thing we want to rule out is that he's having an MI or a heart attack, myocardial infarction. This can present different in different people. There are, kind of the typical signs that you look for, but you never know. Biliary tract disease is another thing, and kidney stones and gastritis. These are kind of where my top 4 differentials. And as far as things that I could do or wanted to do, we're thinking of an EKG to rule out that MI, a stat CBC, because we're looking for an infection, right? For those biliary tract disease or the kidney stones. We want to check a urine dip. He said he was having the bright, or not bright, but like dark red urine. CMP, we're looking at his metabolic panel, amylase, lipase, for that biliary tract disease, the kidney function. The UA with microscopy, this is going to give me more information than the urine dip can. And then an abdominal ultrasound. He's having, some abdominal discomfort, but if I want to really look at that kidney stones, biliary tract disease, I need an ultrasound. The thing is, when am I going to be able to do that? Because I don't have ultrasound available in the office. Are there any answers back from some of those couple questions we had asked?
So far, none have come in.
Okay.
I'm seeing, but if I do ever see any, I'll let you know.
All right. Okay, so then diagnostics. I did the EKG, normal sinus rhythm, no evidence of ischemia. So I can partially rule out that EKG. One of the things that rule out the MI. One of the things that you would also want is the troponins, but I didn't have the ability to do that and get them stat. Like if he went to the ER, for example, they would have done that, and they would have that back within, just a few minutes, maybe a couple hours at the most. His stat CVC, I did do that, and it was normal, no signs of infection, no signs of anemia. His urine dip, the urine was pretty red, dark red. The bilirubin was 3+, and he had nitrates and lukes, which they're kind of indicating a urine infection. But then the rest of the stuff I wouldn't have available for 24 more hours. So I wouldn't know about his abdominal ultrasound, his kidney function, and the biliary tract disease labs. I wouldn't have that for a little bit longer. So at this point, all I knew is that this patient, something didn't smell right. And that was just my gut feeling, is I don't like that this patient is having this pain for about a month that got worse last night. And it's only better now. He wasn't tender. My physical exam he was just mildly, diffusely tender, but he had tramadol. Tramadol is a control medication that's for pain. I didn't like he had green stools, and I didn't like his red urine with the bilirubin. So I had this patient go immediately to the emergency room for suspected biliary tract disease. He needed an ultrasound right away, and the reason I didn't want him to just maybe go home or come back and follow up when your labs are ready kind of thing is my concern was cholangitis. And cholangitis is a huge it starts as an infection of the biliary tree, and it can lead to many complications. So here's a quick anatomy review. Let's see here. I really like this. Well, this is just what the biliary tree looks like. And this,
quickly say, we got two responses, acid reflux and UTI.
Yeah. So those were some of the things that I was concerned, right? But and he did seem like he had a UTI with the urine dip, but those other things like the dark red urine and the poop that was green, those are not you're not typically going to see that with a UTI or with the acid reflux. So there was something more going in there that we needed to look into. So with all of those things, it led me to the biliary tree. So I love this drawing I found on Google, but this is what a gallstone's journey kind of is like. So the gallbladder will store bile that the liver makes, and here's where gallstones can form. A lot of people have gallstones and they don't cause any problems. They might get what we call biliary colic, which is just kind of a sharp pain every now and then. It might be worse with certain foods, but it just goes away. Nothing happens. At that point, you typically would get like an ultrasound to confirm, and then you can have elective surgery to get your gallbladder out, depending if you have too many stones or whatnot. But if that stone moves out and into the cystic duct and it gets stuck in there, you can have an infection. And here you would start to see those signs of infections like fever. You might have nausea and vomiting, the leukocytosis, which is high white cell count, and then the Murphy's sign. So what I was asking about a couple slides ago about Murphy's sign, this is a physical exam kind of maneuver we do to test for gallstones or cholecystitis. And basically we have the patient take a deep breath in at the same time that we press under the right rib cage and kind of into the gallbladder. And so if they breathe and we press at the same time, that can be painful, and they'll stop their inspiration because it's painful. And then that it's usually consistent with cholecystitis. So we have that. Now, if that stone keeps traveling out and it makes it into the common bile duct, this large one here, then it's called choledocholithiasis. At this point, we are going to see jaundice and high liver enzymes. So jaundice is that yellow discoloration of the skin from high bilirubin. Patient might not have high white count, but we have those other signs. Now, if that stone keeps going down and down and down, and then it gets stuck here at the end, this is called the ampulla of Vater, where it kind of releases into the duodenum. This is what I was concerned about for that patient, is that eventually he could get into cholangitis, and so that would be the abdominal pain with fever, with high liver enzymes, and it could lead into sepsis eventually. So at the point I saw him, it was kind of early on. He didn't have a lot of these signs, but I just had a gut feeling that this patient, we need to get him to the ER so that we can avoid this. And this is just another, this is from osmosis actually. Kind of typical things that you would see with abdominal pain. So, and the bile duct disease, the things that would stick out, we call this Charcot's triad. It's when the patient has fever, right upper quadrant pain, and that yellowing, that jaundice. And it's a Raynaud's pentative. They also have hypotension and confusion. This patient, before we go on to the next one, eventually I saw him back in the family medicine clinic, and he went to the ER, not that same day, but the next day in the morning. And by the time, it took him a minute before he could get to the ER. And he said, the first thing he said was, "Thank you so much for sending me," or actually, no, I'm sorry. I think he went pretty soon after that same day. But he wasn't able to get all the procedures done for a little while, because by the time he got there, his white count had gone up, his bilirubin was up, all his labs were altered by the time he got to the ER. And they did the ultrasound, they confirmed he had so many gallstones, and he just had so many things, and some of these things just went wrong, and for him in the hospital. But he basically said, "Thank you so much for sending me to the ER when you did. The doctor that saw me there said that I made it just in time to avoid really bad complications." And so they tried to do a cholecystectomy, laparoscopic, but then the stones were too big. So then they had to, close him up and then open him up again. He had to have a few other procedures because the stones were now by that common bile duct farther down near the ampulla of Vita. And I mean, it was just a huge thing. That's why I said I'm never gonna forget this patient. And this will happen when you see patients that you treat. And I didn't necessarily know. This was, like I said, one of my very first kind of complicated patients. I didn't exactly know, and obviously I kind of jumped to the very end, is that cholangitis, which I actually added that later on after I figure out what had happened. At that point, when I was treating the patient, I wasn't necessarily thinking of that. I just knew he needed more help than I could give him in the clinic, and that will happen a lot of time in urgent care, primary care settings. So you have to make a decision to where to send the patient to get the help they need, so that their condition doesn't get any more complicated. And you won't always know exactly what the patient has, but you're going to be able to, from having the patient there and from your knowledge as to where does this patient need to go right now. Are they okay with the treatment I can give them now, or do I need to send them out? There's another case study here. Let's see, we have a 24-year-old female with vaginal discharge. She's been complaining of itching and discharge for about 2 weeks. She did have unprotected sex with 2 male partners, no other symptoms. So next thing we're going to do for any kind of vaginal complaint is a pelvic exam. We have to look at the patient. If they were having a cough, you would look in their chest, listen. So with these complaints, we have to do the duty and look at their, do their pelvic exam. We're also going to take a swab, and we're going to send that swab for vaginitis and the STD panel. On exam, we see no lesions. The cervix is a little bit red with a lot of discharge, and this discharge looks kind of off-white, thick, lumpy, type of cottage cheese consistency. So what are the differential diagnosis here? Is a yeast infection, bacterial vaginosis, or any of the STDs, trichomonas, chlamydia, gonorrhea. This is a tricky one because when you do a swab, you're not going to have those results for maybe like 3 to 5 days, but that patient is in some discomfort. They're having itching. this particular patient also had unprotected intercourse, and she doesn't know if she's been exposed to any STDs. And then obviously she has a lot of discharge. So we have to give them something for the symptoms. But here's the thing. The textbook will tell you, right? Yeast infection, the discharge typically looks like cottage cheese, thick, creamy consistency. But I couldn't tell you a number of times I have seen discharge like that comes back and there's no yeast infection and it's only BV, or it's maybe BV with chlamydia. So, and then there are other times when it doesn't quite look like that. It looks maybe, more kind of fluid or whatever. And you're like, oh, this maybe is trichomonas. And then the thing comes back and it was only a yeast infection. So everybody's different. And the book is very helpful. That like the textbook, images and stuff or descriptions. But in real life, it doesn't work that way. And the most accurate thing is going to be waiting for those results. Now, in the meantime, you can go with the description or what you're seeing and the complaints. So we're going to give them fluconazole. That's going to help with the itching. We're going to educate this patient on different kinds of discharge and protection, using protection, because also she's having multiple partners. And then I'm going to talk to this patient about prophylactic options. Why? Because Flagyl is the medication we use for BV, and several patients, they know what this is and they've had a history of BV. So they're going to also help you kind of tailor the treatment, and they'll say like, yes, I always, it always looks like that. I really feel like it's BV. Or if it's the STDs, then we're going to look into like, okay, is she exposed? What are the chances? The thing is, you don't want to give this patient like treatment for all the things because you're over treating this patient. Nothing's going to happen if you wait like 3 more days and then you can treat what she actually has. So this is just a kind of generic case study, but I do this all the time. I talk it out with my patients, and based on what I'm seeing for this one, I might say, okay, we'll do fluconazole or like diflucan for the yeast infection. And then I'll call you back in 3 days and see what comes positive. If you have any of the STDs, I'll send in the prescription, or you can come back and get the injection. Ceftriaxone is for gonorrhea. Other times the patient will say, no, I'd rather get all of this right now, like the injection and the pill for the STD. So that's a lot of discussing with the patient and having the patient lead the care also. All right, I have another one. Let me know how we're doing with time. I know we have a little bit, I'll probably have like 2 more cases. This one, another, I think.
That's completely fine. We have about 25 minutes or so and a few questions. Okay. So yeah. Did you want to maybe, before we get to this case, just answer a few of the questions?
Yeah, we can do that.
Yeah. So our first question, and we'll just go in the order that we received them. So if you happen to have more questions, by the way, to the students listening in, feel free to type them in, but we might not be able to get to all of them with how many we have. But the first question is, what are your thoughts on being a psychology major as a PA, as a pre-PA student?
I think psychology would be amazing. One of the common complaints you see in, primary care family medicine is mental health. And you're going to see mental health issues in pretty much every specialty because, you're going to be dealing with patients. So if you are passionate about that topic, I think that it will translate into your future practice and it will still be very useful. So I think psychology would be a wonderful one.
You also mentioned the 5-year program earlier. So what's the success you've seen that with your all other colleagues? Would you recommend it to someone else?
Yes, I think the 5-year program it's great because you graduate high school and you go into this program. There's a few different ones. Some you do like as soon as you start undergrad, you're going into PA. Others will have you go and do 3 years, and then like by your second year, you have to apply for the last 2. That will be the PA program. But I think it's a really unique path. You would graduate very young. And sometimes that can be a challenge, I will say, because you are going to be a very young provider. Usually you don't have, a requirement or either enough time to go on and get some patient care experience. Like, for me or for most people that go the regular route with like 2-3 year program, you're going to have to get X amount of hours in patient care. And so that patient care experience allows you to grow in confidence in dealing with patients and different personalities and things like that. But when you go into the 5-year program, you don't have much of that, so that can be a challenge. And then there's always the patient that will say like, are you even young, are you even old enough to be my provider? That's the challenge I would see. But it's something that you can easily overcome through those 5 years. And even with that, if you still go out and volunteer some, or if you still try to have a job, that you can get some experience with patient, it will help you with that. Many of my classmates were in the 5-year program, and then we just kind of got to the PA section together, and they were great. They were very smart. These 5-year students, they are just like, on a timeline. By then, because you do undergrad in only 3 years, you're already kind of used to, and this is what I've gathered from them, is that you're already used to the high intensity and the demand. And then when you get to the actual PA program, which is very demanding, it's not as much of a shock, because in undergrad you were already like just going. So it's a good opportunity, definitely.
Yeah, it's really appreciated to hear from your experience. Another question we have is about if you ever considered PA versus MD.
I personally didn't. And like I said, this is because I started my undergrad in Venezuela, and the circumstances were completely different back there. Number one, we don't have the PA profession in many other countries, and not in my country. So it was never an option. Then when I transferred to the US and I was doing my undergrad here, I was so focused on finishing my undergrad as a dietetics major that even when I was doing my clinical rotations for dietitians, I still didn't even know about PA. And my interest was really just becoming a dietitian. Back home, I thought about medicine for like one fraction of a second, but the socioeconomics of my country they weren't very conducive to the lifestyle I wanted to have and the exposure I wanted to have. So I just, I wanted something that wasn't so involved, like procedure back then. I mean, I was a whole different person. I didn't even want to do any kind of procedures. Now I love procedures. So that's another one of the things that, things will change, your interest will change. But for me, no, and even when I decided to go back to school, as a physician, or going into medicine, like medical school, you would have to choose a specialty, and that's one thing that I could not commit myself to. I like so many things, and I didn't have one specific thing that I would see myself doing for the rest of my life. So in that sense, even if I had considered it again, it wouldn't have worked out.
Kind of a follow-up question to this, and the student just prefaces that it's not in any rude way, it's just out of genuine curiosity, to being an MD versus a PA. Do you feel as a PA that you don't necessarily have as much information from training as a physician would?
Definitely physicians will have a greater knowledge base than PAs, because medical school is longer. And then not only that, but they also have specialty training, right? You have those years of residency. PA school, it's a 2-year master's program, and it's designed, or it's modeled after the medical model. So we kind of learn the same things, but we have this really short education. A lot of our training, I would say, is kind of in on the job and like in rotation. So even though we do have a full year of rotations in every major area, the because we're able to jump from different specialties on, you're going to get a lot of that training on the job. And the knowledge base for us, I feel like it's going to go kind of secondary to the provider that you're working with, to the physician that you're working with. So in family medicine, for me, it would have been like with the providers that I was in, any questions, any things I would, initially I would discuss with them. Now in this job with maternal fetal medicine, which eventually he actually wants me to scope out of diabetes and more into the entire world of maternal fetal health and medicine. But I would learn based on what he's teaching me. So that's why a good relationship with a physician is important, because they are going to, in a way, be your trainer and your mentor. So I hope that kind of answers the question. Now, as far as practicing, I don't feel that I have inadequate or like too short knowledge, because I'm equipped to diagnose and treat, because the education in PA school is still complete in that sense. But you'll just continue to learn more and more on the job.
Absolutely. Yeah, definitely addresses the question. We'll take one more question and then hop back to the case studies. Hopefully we'll be able to get as many questions after the case studies. But our last question before we hop back is, when you discussed family practice versus urgent care, even though they're pretty similar, did you enjoy one more than the other?
That's a great question. I think that if I said I did, it's mostly because of not the specialty, because they're very similar. The only group that it's not in my primary care job is the babies. But it was more of the environment and like the administrative part of the jobs, which is why I ended up looking for another job. But no, the specialties I would say is pretty similar. Now, internal medicine, which is kind of similar, because it's just another specialty that I've considered. The difference is that in internal medicine, you see patients older than 18. So right now, I'm just not seeing the little tiny babies, but I see kids. And then if I went on to, maybe if I didn't like kids anymore, then I would go into like internal medicine, which is still general medicine, pretty broad, but just not that patient population.
All right, well, that's all the questions for now. We'll go back to the case studies.
All right. So this is a kind of a patient that I would very often see something like this. A new patient, uninsured, he's Hispanic, and he came in with frequent urination. A patient that's noticed frequent urination, lots of thirst, hungry all the time, and bilateral foot pain. He's a truck driver, eats a lot of fast food. Because he's a truck driver, he can't exercise much. He does drink coffee and Red Bull daily. As far as other symptoms, not much else. His past medical history, he's obese, high cholesterol, kidney stones, family history with type 2 diabetes, heart disease, colon cancer. His vitals, I kind of highlighted the things that were abnormal, but his blood pressure is 178/100. Normal is less than 120/80. His BMI is 36. And then his general physical exam was pretty benign, but his neuro, he does have decreased vibratory sense in the great toe, and monofilament felt only above metatarsal. So I think I have a picture here. I deleted the picture, but these two last things on neuro exam are specific for diabetes neuropathy. So high blood sugars can damage the eyes, the kidneys, the nerves. And when they've had high blood sugars for a long time and they start to have this pain, it's because it's gotten to the nerve. His urine shows protein and glucose. His sugar and the glucometer is 358. That's pretty high. And his A1C is 12.7, and normal A1C is like in the 5 range. So that's very high. Other blood tests that I would order, remember this is an uninsured patient, so we want to really limit what things we're doing for him because he just doesn't have the means to pay for it, but we want to know his lipids and his kidney function at the very minimum. So how do we diagnose diabetes? This is just a quick kind of chart here. But either if we have, like for him, we had a random blood sugar, the random in a patient with symptoms, like he has symptoms, right, with the urinary frequency, the thirst, and the plasma sugar was 300 and something, over anything over 200 with symptoms is type 2 diabetes. And then the A1C, we also had that. His was 12 or 13, anything over 6.5 is diabetes. Typically, you need 2 tests to confirm. So we had those 2 different ones. And then if you remember, his blood pressure was also high and it was like 180 over 100. So we are looking at this table here. He is in almost like in a hypertensive crisis, right? So this patient was on no medication, and this I've actually seen this situation many times, and even in young patients. I recently had a very young patient under 30 with a similar situation, and they'll get diagnosed with both high blood pressure and high blood sugars on the same visit. So it can be very overwhelming for the patient. So what are we gonna do? We're gonna kind of break it down as much as we can. Like I said, it's very overwhelming. So I would typically give the patient kind of a, 5 tips that I want for you to know as far as your diabetes goes. And I break it into lifestyle changes. So exercise and your meals. I want you to eat 3 meals, 2 to 3 snacks. Your drinks. I don't want you to drink any pop, any juice, things that have sugar, no alcohol preferably. Mostly water. Next is we're going to test the blood sugar. So at least the fasting, sometimes depending on the patient, we'll have them check twice a day or a little bit more. And then the last one is going to be medication. So all of this slide is just breaking those things down. And then the medication for him, it's going to be metformin. That's going to help his blood sugars. Some of these medications you have to start slow. And so this is one of the things that I'm very passionate about is educating the patient and working with what they feel comfortable with. I never want to tell a patient like, you need this and you need to do this. And, I will explain like, this is what I would like for you because of these reasons. What do you think? And I like to work with them pretty frequently. So this is somebody that I will probably see again in at least 2 weeks, maybe 4 weeks. And then we also have to take care of their high blood pressure. So we're going to start some medication like lisinopril, which will help the blood pressure, but will also help protect the kidneys for diabetes. We're going to put him on a statin for his cholesterol, and we'll talk again about the diet, no caffeine. I know he's a, truck driver, but still we got to cut down on that because it's not going to help the high blood pressure. And this is just a very simplified way of what the treatment would be. But most of the time here, I would spend it on patient education and kind of working with them on what they can really accomplish. And then this is just a very quick one. This is the last one, a lump on the skin. Very, very common, especially in the urgent care setting. This is a patient that had a red lump on the thigh for like 4 days. It's now tender, increasing in size. They said some purulence are coming out this morning. No fever, chills, no other symptoms, but they do have a history of IV drug abuse, hepatitis C, obesity, and they're a smoker. So then when you go on to see the patient, this is what you see. This is just a photo from Google, but something like this. This is an abscess, and this is procedure time. For something like this, we would do an incision and drainage. So again, this is another picture from Google, but this is one of the very, very common procedures we would do in urgent care. So we're basically using some local anesthesia around the abscess. This is something you learn with time in practice because do this procedure, they have to be pretty fluctuant so that the pus is already, liquidy and will come out. Sometimes it's not, it's like indurated still, so hard, and then we just have to give them antibiotic and have them maybe come back in a couple of days, put some more compresses. But for this, I would do an IND. These are very kind of fun procedures. Yucky, you get all the pus out and then you pack it and send them on their way. And then, for somebody like this patient that had a history of drug use, IV drug use, then you want to be aware of like MRSA and, what kind of antibiotics you might want to put them on, and have them follow up with their provider. So that is it.
Right. Well, thank you again so much, Gaby. This was an amazing presentation. Like I said earlier,
thank you.
We have a lot of pre-PA students, a really growing number, especially over the past summer. And there's a lot of interest for this session for sure. So just to go back to our questions where we last left off, the next question we had was about how much time you get with a patient. So do you feel like you ever get enough time to actually spend with a patient, go through their history and all? The student asking says that they assume most patient visits are around 15 minutes at a time, if that's correct, or 30 minutes. So is that 15, 30 minutes enough time for you?
That's a great question. I feel like my jobs have been unique in that sense. Yes, most of the time you are going to have, patient schedule every 15 minutes. At my first job, it was very like, it was a first come, first serve patient, walk-in clinic, very busy, but because I was a new provider there, I didn't have a heavy, patient base or anything like that. And I usually had like even 20, 30 minutes with my patients. And then on my current job, primary care and urgent care, we're a new clinic. I actually didn't mention this before, but this is a brand new clinic. So we started in April from 0 patients, brand new facility. And now I'm getting up there into like, I see maybe like 15 to 20 some patients in a 12-hour shift. So I usually do have a lot of time with my patients, like especially if I have a patient that they're the only one there in that entire hour. I could spend the entire hour with a patient if I wanted, if he wanted. So I've been lucky in that sense. But that's not going to be true for most jobs. And my suggestion in that case, which I sometimes do have to do, is break down and kind of prioritize their complaints. What is most important? What do we need to address first? And then have them come back in a couple of weeks or in a month more often than you would normally, so that you can keep addressing those things. And the key is in the follow-up, especially in something like primary care and family medicine.
Our next question is about, you mentioned earlier treating it like an interview. I think this student they're just asking what you meant by that. I think they're referring to at the time when you were talking about approaching patients. I believe so.
No, so treat every job like an interview. I think what this is when I was talking about like your patient care experience, any volunteering opportunity, every encounter you have with other providers, treat that as an interview, because say, just to give you an example, is all of my jobs that I've had as a PA, I've obtained from networking, from rotations. I never applied for any of these jobs because either like somebody reached out to me from my previous one, and then the 2 other ones have been from rotation. So everywhere you go, like be sure you are, professional, that you are kind of happy and smiling and polite, that kind of stuff. And if you think, just stay in touch with the people that you're meeting in this area, because they can help you maybe with the letter of recommendations or referring you to another job or something like that.
All right. And then another question is about how you felt after graduating. So after graduation, how long did it take you until you were confident with seeing a patient without second guessing yourself or calling another provider?
Yeah, that's a great question. It takes time, and even I'm still consider myself a little bit of a new grad. I'm just marked my second year as a PA, and I still will look on like up to date. I will still double check antibiotic dosages, especially like for kids. I will still maybe for I will talk to my physician or like send them a picture or something, if like I'm not sure. So those hesitations or concerns you'll always have. There are things that you'll, be more confident and comfortable with. I would say for me, it probably took like a good 6 months before I stopped coming back home overwhelmed and stressed. Like, because at the beginning, I just had to look up every single thing, or like I had to discuss with one of the other providers and be sure. And a lot of it is reassurance because, like I said, you do learn a lot in PA school and you do learn a lot in rotations, but it's just that confidence that takes time. And that feeling of being overwhelmed with how much you have to know. Probably a good 6 months to a year. And then if you switch fields, then you're kind of like starting all over again, right? And you have to be okay with that. And then I will say, I don't think you'll ever be 100% confident because there are always new things that you are going to keep learning. Every patient is different. Maybe you've seen shingles 100,000 times, but it's that 101 patient that will show up different, and you'll still learn something and you'll still be like, oh, I'm not sure. So collaborate with your colleagues and be okay with asking or telling the patient, give me just a second, I'll be right back, and then go kind of figure it out.
Absolutely. We'll go through a few more questions before we close. The first one we have is, being a dietitian, as part of your past background before going for PA school, how much of a leg up did that give you? How much was it mentioned in interviews? How much do you think it helped your application?
In my particular case, I'm probably going to say a lot because that was my only experience. My only patient care experience was those good 3 years of working as a registered dietitian. And one of the things for me in particular was my interest in general medicine and how that aligns with the goals of the PA profession to expand access to healthcare. And then at the same time, we have this obesity epidemic and diabetes, that's being kind of poorly managed. So I was able to use that experience as leverage and kind of show what I have to bring to the table. And some years later, I'm pretty proud to say that I've stood kind of my end of the deal, right? Like I wanted to join this profession to help the patients with diabetes and in primary care, and that's exactly what I've been doing. So I would say in my case, it was a whole lot.
And our last question for tonight. So you worked in primary care, you worked in urgent care, maternal fetal medicine. Are there any other fields that you're interested in joining too?
Yes, there are. I actually did a rotation in school that was in interventional radiology. It was my elective, and it was amazing. All the procedures we did, the fluoroscopy and doing like pulling liquid out of the lungs and thoracentesis and things like that. It was a really fun rotation. But I don't think that it would have been something for me to like start right away, but it's something that I have pending. And actually, when I was just looking for a job earlier this year, I reached out to that preceptor. I said, hey, I'm looking for a job. Is there anything maybe like available right now? And he said, not right now, but I do have you in mind, because from that rotation, I received like really good feedback. And so again, I'm like trying to stay in touch. So if something opens up in the future and I have some time to do that, that would be great. But yeah, I have interest in that. Now that I have a baby, I kind of like pediatrics a little bit more. And OBGYN, I absolutely love. So I'm hoping that throughout the next several years, I can continue to explore.
Yeah, sounds really exciting. We love that lateral mobility, like you mentioned earlier, where you can
Yeah.
dip your feet into different specialties. But that's a perfect place to wrap up today's session. Again, thank you so much, Gaby, for joining us. I have a few reminders before we end for our shadowers. So to our shadowers, especially if you're new, we have a process where you can earn attendance or earn credit for your attendance. So we have a quiz that was prepared, 10 questions. And once you pass that quiz with at least 6 out of the 10 questions correct, or 60% at least, you'll receive a certificate. That quiz is now posted in the chat box. It's also available on our website under the virtual shadowing page. The quiz will be due at 11:59 p.m. Central Standard Time this upcoming Sunday, October 9th. And after passing that quiz, like I said, you'll receive a certificate. The certificate will specifically be sent to the inbox of the email address that you list on the quiz. So be sure to list it with an address that works for you, that you are comfortable with. We highly recommend using a personal email. So that's Gmail, Yahoo. Sometimes school emails will filter out these sort of messages. And just in case, let's say you don't find it in your inbox, please check your spam folder or feel free to reach out to us. Our email is shadowing.h, the number 4h at gmail.com. And like I mentioned at the beginning, we have multiple shadowing sessions happening each week. So later this week, we're going to have another shadowing session on Thursday, October 6th with Dr. Jillian Regert. She is an oral an oral medicine specialist. She actually has not only an MD, but also a DMD. So she has quite a lot of experience. She was also an Air Force veteran. We actually have seen quite a few veterans coincidentally over the past few sessions. And I think actually our next PA might also be a veteran. I might be mistaken there. But like I said, that's going to be this Thursday, October 6th at 7 p.m. Central. We do have multiple specialties on board. So Dr. Regert is to do with dentistry. Gaby today was to do with PA. And next week we have another PA. If you have any certain specialty requests for us, or if you have actually like a specific provider name that you'd be interested in seeing, we can try to reach out to them. Please list it on the quiz under questions or comments. That's the last blank on the quiz. That'd be greatly appreciated. And like I mentioned at the start, if you ever want to follow us for more shadowing sessions, you can do so by following us on Instagram to keep an eye on the flyers that we post, or subscribing to our listserv. And you can send us your name and your email address and go from there. I know, Gaby, you have an Instagram handle. So if any students have questions for you.
Yeah, you can find me on Instagram at it's Gaby the PA, and I also do have a podcast that it's called The Making of a Physician Assistant, and you can find that on Spotify and Apple Podcast. I think it's just a really good, resource, because you won't only hear it just from like my experience, but I also do interview other PAs and many different specialties. So highly recommended. That's The Making of a Physician Assistant, and my handle is at it's Gaby the PA.
Absolutely. That sounds like a lot of insight there. Definitely check it out. I'm sure a lot of students would be very interested just from their interest today with today's PA session. But again, thank you so much, Gaby. We really appreciate it. Hearing from you was
sure. Thank you for having me.
Absolutely. Such a blessing. And to everyone listening in, we look forward to seeing you later this Thursday. Again, if you have any questions for us, please feel free to shoot us an email or even DM us on Instagram. But until